Yeah, I will say out of all of the conditions, OCD is one of those conditions that I would say really responds to psychological behavioral management
Yeah.
more so than a lot of the other
Yeah.
DSM
Yeah,
conditions.
there's something neurological about how the brain works and how fear is conditioned, how compulsions essentially feed into the intrusive thought cycles. That once we provide education and help people respond differently, there's like some sort of rewiring that happens and people get better.
Yeah, it's amazing. Also, that's why I asked you about remission and everything too. 8 to 10 years, huh?
Yeah.
Wow.
Yeah, depending on the studies.
Of course, yeah.
But yeah, people once they get it and they get the principles, they could just, they sort of like live their life, and it's pretty powerful stuff.
Okay, ready to go?
Let's do it.
Okay, awesome. All right, everybody, welcome back. My name is Dr. Thomas Hughes, but you know now not to call me doctor. Don't call me doctor. So we're back. Got another episode for everybody. I'm joined today by Dr. Max Maisel.
Mm-hmm. Feel free. Max is totally cool.
Right. All right, cool. Max is fine. Okay, so today we're going to talk about OCD. All right, but before we begin, I always let people introduce themselves. So, maybe there's something you want people to know about yourself. So go ahead, tell everyone a little bit about yourself. What do you do? Yeah, go ahead.
Sure. So I'm a clinical psychologist, and I practice in the South Bay of Los Angeles in Redondo Beach. And I'm the founder of Beachfront Anxiety Specialists. So we primarily work with people who have OCD, Obsessive Compulsive Disorder. But we also work with people who have OCD-related concerns, like we see people with tics and Tourette syndrome and body-focused repetitive behaviors, which is essentially skin picking, hair pulling, things in like the OCD family. And myself and my clinicians, we're all very passionate about using evidence-based practices to help our clients get to a better place.
You mentioned, you kind of pointed out they're evidence-based.
Mm-hmm.
All right. We're going to talk real here because there's a lot of people practicing that don't practice evidence-based.
Yes, that is all too true, unfortunately.
Yeah. What? How often do you encounter patients that have not been receiving evidence-based? Is that most of your new patients, or do you mostly get people that have never had any type of OCD therapy at all?
It's a really good question. I'd say the vast majority of clients that we see have had many years of traditional talk therapy. It's not their first rodeo in therapy, and talk therapy obviously can be helpful and has its place, but it's definitely not gonna cure OCD.
Right.
And in fact can make it worse, as I'm sure we can talk more about later. So I'd say, like, I haven't run the numbers, but probably 75-80% of our clients have had some prior experience with like non-OCD specialized therapy.
Yeah, we have to talk about that.
Yeah.
Seriously, because as I found out in residency, I had someone who was an OCD specialist with me, and it was just difficult because he had to walk me through just the mindset of somebody with OCD, and the type of therapy is very specific. Mm-hmm. You can't just do regular CBT for those patients. So
right.
Yeah, we have to talk about that. So let's get specific then.
Sure.
Okay, we're talking about OCD. I think most people have an idea about what obsessive compulsive disorder is, mostly because of TV, the internet. Okay,
sure.
But let's hear it from a clinical perspective. What is obsessive compulsive disorder? What is that?
So obsessive compulsive disorder, there's two important components to it, and it's in the name, right? There's obsessions and there's compulsions. And obsessions you can think about as any thought, feeling, urge, or sensation that causes immense distress. People don't like them, they don't want them, they try to push them away to get rid of those yucky thoughts and feelings. And usually they cause all sorts of really painful, uncomfortable feelings like anxiety, doubt, uncertainty, but even things like disgust, shame, embarrassment, guilt, all sorts of just yucky feelings. And then the compulsive part, compulsions, are how people respond, how they cope with those initial obsessions. So usually people get these horrible intrusive thoughts. They feel so bad. They're overwhelmed with debilitating emotions, and they do what they feel like they need to do to feel better or to protect themselves, which would be a compulsion. So essentially you could think about obsessions make anxiety go up. They create distress, and compulsions are designed to make anxiety go down, designed to help people feel better. Now, it doesn't always work like that. And when it does work, it's temporary relief, but that's the nature of the disorder.
Right. So we have OCD here. And I think the key here with all of the DSM It's how much distress that it actually causes you and whether or not it interferes with
Yeah.
your life.
Of course.
If you go out into the world, you'll hear people say all the time, my OCD is making me do this. My OCD is making me do that. And I think we use those terms a little bit too flippantly because there are people that really are going through distress and struggles.
Yeah.
One of the things I did want to talk to you about that you mentioned earlier, that person that you said had debilitating OCD.
Mm-hmm.
Okay. So I don't want you to go through what this specific case was.
Sure.
But when you say debilitating, could you describe that a little bit more in depth and how bad or severe, I should say, some of the symptoms of OCD can be?
Yeah. I mean, essentially, people with when they have the diagnosable disorder of OCD, even a mild case is severe, isn't great. But essentially, OCD can absolutely encompass every single facet of somebody's life. And somebody with a severe case, pretty much 24/7 or every waking hour, they're going to be struggling with some sort of horrible, intrusive thought or some incredibly uncomfortable, overwhelming feeling or sensation that's in response to that intrusive thought. And it can make it impossible for people to concentrate, to be present. A lot of my clients have described it to me as like living in their own waking nightmare inside their mind that they can't get away from.
Right.
And it's like absolute hell for a lot of people. Really, really, debilitating in the worst possible ways. And I think like OCD is particularly one of the most vicious sort of like forms of anxiety because not only do people get so stuck in their obsessive thoughts, but most people with OCD, they understand the nature. They understand that their obsessive thoughts really aren't grounded in reality, and
they know it's not real.
They know so deeply, but it gets them so trapped, and it could just feel so crazy making, and there's so much shame involved in it because of that too. So you asked before that if I see a lot of people that have been through therapy in the past, and for the most case, I have, but oftentimes people put off coming to therapy because there's so much outward stigma, but also just internalized shame about what they're going through.
Yeah, I mean, I think what you're talking about here is, in terms of debilitating, is people that really can't leave their house.
Yeah, absolutely.
Can't leave their house because, I don't know, they can't turn the doorknob enough times.
Yeah, they get stuck in loops and cycles.
Yeah, they're worried about germs. I think, is that the most prevalent or the most common concern, germ concerns?
We see germs and contamination OCD. Oftentimes, usually the clients I see have more than one theme of OCD.
Okay.
So contamination, especially in the era of COVID, where germs and contamination are on the news like nonstop. OCD can't help but like grasp on that. But we see people with all sorts of themes that their OCD attaches to, and usually OCD targets what people care about the most. For example, people oftentimes care about their loved ones, and they're some of the most kind, gentle, loving people. So their OCD often targets that, and people worried that they might do something bad or hurt somebody that they care about. And that could be just as debilitating also because that targets their core values, right?
Yeah.
Not only are they terrified, but then they can't help but question the sort of person that they are.
Yeah, so when you mention shame, some of those obsessions can cause shame.
Oh yeah, absolutely.
Right. Meaning I have thoughts of hurting this loved one or doing certain things to loved ones, and that's something they don't really feel comfortable talking about.
Yeah. And especially when OCD is portrayed in the media in certain ways, and people believe it has to do with hand washing or ordering things.
Exactly.
And they don't attribute that to OCD. They think there's something seriously wrong with them as people. And there's absolutely not, other than having a mental health diagnosis of OCD.
How far away from what actually happens on TV versus what you actually see in real life, how far apart are those two presentations?
Like night and day. It's incredibly far apart. And what bugs me the most, right? And I even hesitate to say this on here with you because it's such like an offensive thing in like the OCD community. But when people say, "Oh, I'm just a little OCD," or like, "Oh, they have a little OCD," that's it. And we see that a lot portrayed in the media, where OCD is sort of seen as like a preference, like, "Oh, I like things to be cleaner," or "I like to wash my hands a little bit more," or "I'm a little bit careful about how things are ordered." And that is not, OCD has nothing to do with a preference. Nobody can be a little bit OCD. As we talked about, it can be an absolutely paralyzing mental health disorder. But when people see that, not only do people who actually have OCD cannot feed into the shame cycles, but it sends out absolutely the wrong message about what OCD is and how people are able to like identify some of the less talked about types of OCD.
Yeah. Yeah. I mean, and we're getting into what we egosyntonic and egodystonic personality disorder versus OCD. Could you explain the personality disorder aspect of it? What's the difference between that and actual obsessive compulsive disorder?
Yeah. So usually when people have like an obsessive compulsive personality disorder, they're not going to want to come into treatment, right? They're going to have like a family member or a friend, or things have gotten so bad where they're sort of forced to come in, because why would they? Because they're right? There's nothing going on. It's their way is preferable, at least internally to them.
They like it.
Right?
Other people don't.
Exactly. And that's like the definition of egosyntonic, where it kind of fits their identity and who they want to be, who they are, versus obsessive compulsive disorder. It goes against everything about who they want to be, who they are as people. And oftentimes it's just like such a miserable experience, and people desperately want help.
Right.
And yeah, definitely an important difference there.
Okay. Yeah. So there's a difference between a personality disorder and there's a difference between a OCD. There's OCPD and there's OCD, a very important distinction. And then there's just normal variants. Okay. So what age group do you work with typically?
So I actually see all age ranges.
All age ranges.
My youngest client's like 5 or 6. My oldest are past retirement age.
Okay.
So I work with the whole like lifespan.
Okay. The interesting thing about that is the idea that a 5-year-old might have symptoms of OCD. Is that what I'm taking from? Okay.
Yeah.
Okay. What does that present differently from somebody that's in their 20s or 30s? Okay. How does it look for someone that's pretty young, between the ages of let's say 5 and 12 or 13?
Yeah. So a lot of it will depend on insights too. Like younger kiddos aren't going to have as much of an insight into like what's going on or the nature of anxiety, or be able to take a step back and see things from different perspectives. But oftentimes OCD will just target things that are relevant to them in their lives. For example, kids that age will have somewhat recently been bathroom trained, right? So OCD, intrusive thoughts, might target that, and they might worry that they're not going to the bathroom in the right way or the wrong way, or the OCD might worry that they haven't wiped enough times. So they'll end up doing things over and over and over and over again based on this OCD intrusive thoughts. Oftentimes it would pick up on school or friends. Kids would get really freaked out that something really horrible is going to happen at school, or that teachers are going to, say crazy things if they talk, and they'll end up shutting down and just be exceptionally scared.
How do the parents, because I'm thinking of this, and at that age, you're trying to figure out what your kid's personality is going to be like. And it's very difficult to discern normal variants, which is what I just mentioned earlier, versus something that you actually need to go see a doctor for.
Yeah.
What are some things that you've seen in the past that might be telltale signs for somebody that might, or for a child that might have OCD at a young age?
Yeah. If the child, a big one is the child repetitively asking parents questions, where the parents feel like they have to lie to the child to get the right answer. And the more they give the child the quote unquote right answer, the more the child feels like they need to ask, where parents feel like they're sort of stuck in loops. Like, I don't know what to say to them. I told them a million times that there's nothing outside the window that's going to break in and like eat them up if they keep asking.
Right.
And that stickiness of it, where parents feel like the more they try to quell the concerns, the more the kid's going to ask questions. I think that's a really important sign. And that's a big part of OCD treatment with the little ones too, is working with parents and helping them to identify what's like the OCD bullying their kid around versus what's just like normal development, what are the normal concerns for that age, and where the child's at.
What I imagine tends to happen is the parent is asking for some level of comfort. The parent wants to give it, adding to the problems of OCD.
Yes. So what we want to say is we want to be firm and boundaried with the OCD, but we want to love and give as much compassion, empathy to the child as we can. And often that is like really helping the child understand what OCD is and why giving them the reassurance they want is actually unhelpful. But absolutely empathizing and validating and like really attuning to the child emotionally is so important. So it's being able to do both. Meet the child where they're at, give them love and compassion, and not feed in OCD cycles. And a lot of the parent work is really empowering children to learn how to stand up to their OCD and how to talk back to their OCD bully and tell them, hey, OCD, I don't have to listen to you. I don't need to check under my bed 20 times. So kind of like to learn for the child to build their own internal voice to fight back against the OCD.
Moving on to pure O. That's what I want to talk about. Okay?
Sure.
So we talked about obsessive compulsive disorder, but you mentioned something when we spoke a few weeks ago that there's something called pure O.
Yes.
What is that?
Yes. So I love the term pure O. It's funny because if you talk to an OCD specialist, they'll always say like pure O with bunny ears on it, and like pure O. But wait, that's a misnomer. Everybody says that, and it is a misnomer, but it's a really helpful misnomer for people.
Okay.
So when you think about traditional presentations of OCD where there's like excessive hand washing or excessive like I'm going to check the oven multiple times, or I'm going to check if the door's locking properly. Those are compulsions you can see physically. Pure O, there are no external compulsions like that, but there are mental compulsions. So there's compulsions happening in people's minds. Mental compulsions, they serve the exact same function, the same purpose as physical compulsions. They're meant to reassure people. They're meant to cope, to feel better. But just like with physical compulsions, it absolutely reinforces the OCD cycle. It makes things a lot worse.
Do you have an example of a mental compulsion?
Sure.
Yeah.
So one that we actually see quite often would be somebody that has an intrusive thought that maybe they're a killer, like a serial killer, somebody that can hurt people.
Right.
So they'll be terrified. They'll have incredibly strong intrusive thoughts about what if I hurt somebody? What if I killed somebody? So say that person needs to go to the mall to go shopping.
Okay.
They're at the mall, they're doing their thing. Externally, you might not see anything weird or different. But internally, they're going to be spending a whole chunk of their energy in their mind trying to make sure they're keeping themselves or others safe. For example, they might be constantly retracing their steps, trying to remember, did I stab somebody? Did I hurt somebody? They might be looking around. Is there blood on the floor? Could I have caused that blood? They might be reassuring themselves. Things like, I'm not a serial killer. I wouldn't kill anybody. Right? They're doing all this mental work to respond to that thought, to try to push it away. But in OCD, whenever we try to push away intrusive thoughts or try to cope with it, that literally teaches our brain that intrusive thought is dangerous. And what does our brain do with dangerous things? It puts them on our radar. You have more intrusive thoughts, more compulsions, and it leads to vicious, horrible OCD cycles.
Oh, so it's okay. See, I would have thought of that as a physical compulsion. They're walking around and everything.
Yeah. So if it could be a physical compulsion.
Yeah.
But if they don't go back, but in their mind, mentally, they review every step they took up until that point.
Okay.
So it's sort of like they're mentally walking back.
Okay.
They very well might physically walk back, and that would for sure be a physical
Then that
compulsion.
would be a physical compulsion.
Exactly.
But if they're thinking about it, or they're driving and they thought that they hit someone, they're thinking about the drive and whether or not they actually did it.
And I've had clients that do that, and also that turn their car around and check. But with OCD, it's usually not enough. So they'll turn their car and check again and again and again. So it can be physical, can be mental also.
Got it. So it's just the thought.
Yeah.
If it's only the thought of retracing your steps, that's pure O.
Yeah.
If you actually go back and retrace your steps, then that would be not regular, but you know what I mean.
More traditional
OCD.
Yeah. And a lot of people have a combination where they do both physical compulsions and mental compulsions. But for some people, it is like mostly mental. And oftentimes when they hear, and the reason why I said it's a helpful misnomer is because when they hear there's something called pure O OCD, and they're like, oh my God, like that's me. That explains everything. And they go from feeling totally broken, even suicidal at points, to like recognizing, wait, this isn't me at all. This is a thing, right? This is a thing that millions of people have, and there's a treatment for it.
Right.
So it could be a really empowering diagnosis. But if you hold on to that word pure O, you might miss out on the mental compulsions part, which is a huge piece of the treatment for it.
Okay. And I think that's an important thing for me to ask you also. And I think you might have answered it with the existence of pure O.
Yeah.
Do you need both obsessions and compulsions to meet criteria, or do you just need one or the other?
It's a really good question. So technically, according to the DSM, it's one or the other. People who work with OCD have never seen obsessions without compulsions, including myself. So there's 99.999% of people, there's going to be some sort of compulsion. It's just putting your detective cap on and being curious, well, what is the compulsion? And again, one way you can think about that is anything that we do in response to the fear that tries to help, tries to protect, is intended to make the anxiety go down.
Got it. So usually you have one or the other, but it's possible, I think, is what the DSM is trying to say.
Yeah,
you can't have one, but usually it's both. 95% of the time it's both.
Exactly.
Yeah. Okay. So I think we have a firm understanding of what OCD is, and pure O also.
Yeah.
Okay. Now, what are we going to do about it? What can we do about OCD? If somebody is listening to this podcast or thinks that they might have OCD, what's the treatment for it?
Yeah.
What do we do?
It's a really important question. So the most widely validated treatment is exposure and response prevention. Sort of a mouthful, called ERP for short. ERP, it's extremely simple, but extremely hard also. And essentially what ERP is strategizing with clients and figuring out how to stand up to our OCD, how to face our fears in a strategic and gentle way where we don't have to do compulsions. So it's sort of like being able to ride out the wave of the fear without trying to make it go away, without pushing it away. And eventually over time, that fear is always going to go down. And when it does, our brain starts learning, oh, okay, well, I didn't do the compulsion and this horrible thing didn't happen. Maybe these thoughts aren't as dangerous as it seems like they are. Right. So when we do ERP, when we face our fears without doing compulsions, it's sort of like we're cutting off the oxygen supply of the OCD and it loses power and people start learning the true nature, kind of like seeing through the smoke and the mirrors of their OCD. And it's kind of really hard not to get better when you're practicing ERP.
Okay. So it's a very effective treatment. If somebody is looking for a provider and they've been diagnosed with OCD and they're looking for somebody that can do exposure and response therapy, what are some of the components of exposure and response therapy that make it quality versus, you can almost call it subpar?
Yeah, definitely don't want people doing subpar therapy for their OCD. Fortunately, it happens all too often. So first off, I want to say that the International OCD Foundation, the IOCDF, has an awesome listserv for clinicians who are at least knowledgeable enough to know about the IOCDF. So I think it's always a good place to start looking for a qualified therapist that can help them face their OCD challenges. And then ERP, essentially what it is, it's really getting a clear view on the relationship, sort of like a lay of the land between all the different sorts of obsessions, all the themes, and the compulsions in one's life. Sort of like how do they interact? And I think it'd be really important to make sure this clinician understands the difference between a physical compulsion and a mental compulsion, right? Mental rituals would be really helpful distinction. And then once you get a sense of how one's personal OCD is manifesting, a lot of it comes down to coming up with this is where the therapy gets kind of creative and fun, different ways to purposely trigger the OCD feelings and thoughts without acting on them.
You want to trigger the responses.
You want to trigger the fear and the uncertainty and all the scary stuff.
Okay.
Without doing the compulsions. And a good OCD therapist will help you do that in a way that feels manageable and in a way that you're really attaining some wins under your belt. So you're not overwhelmed. They're gonna push you very gently, but you're gonna feel in charge the whole time also. And you're gonna feel like you're making progress. You're gonna see your OCD melting away. You're gonna come up with a plan on how I'm gonna face these feared situations. What am I gonna do to make sure I don't start doing compulsions, right? Because it's easy to say, well, don't do compulsions. But if it were that easy, people wouldn't have OCD. So a good OCD-informed therapist is going to really work with you and give you tools and strategies to start chipping away at the hold that the compulsions have over you. Usually people, and there's so many different ways to do the work, but the long and short of it is like making sure your therapist provides you a really good understanding of how OCD works, of how facing your fears is going to help and that you believe them and that makes sense to you. And then together, you start chipping away at it. You start facing your OCD and seeing how much better life gets when OCD loses its grasp.
Yeah, you OCD specialists, you're very creative with the way that you...
to my clients, kind of like chagrin sometimes. Like I feel like OCD's therapy is the only sort of therapy where together you collaborate on how to really like torture people, right?
Yes,
like,
yes.
How do we face this stuff head on? Like, how do we use your OCD? But it's OCD is so paradoxical, right? And it's like, all we want to do is get rid of it, figure it out, solve the problem, and that's exactly the trap. And if we can, like, together with clients, almost like have fun with it and throw a sense of humor and show the OC that we're playing by a different set of rules now, it could be fun. And my goal, I always love when clients start coming up with their own kind of like fun, cool ways to trigger the OCD, where it's like, hey, Max, like I thought of an awesome way to trigger myself on purpose. It's like, that's what you want to hear. That is like ERP gold right there.
Do you have to keep doing it over and over again? Otherwise you fall back into your old patterns of behavior?
Yeah. So usually we want to do consistent ERP, for a couple weeks, a couple months, however long it takes. And then once people get better, we always recommend almost like giving yourself a vaccine and booster shot of ERP. So for example, at first, let's say somebody goes into remission, we probably want to do a couple ERP exercises, maybe like once a month. And then if their gains are maintained, once every 6 months. And then maybe we do it once a year, just kind of poke at the OCD and show it who's boss. So we want to get to the place ultimately, and the techniques and the exposure exercises. And what I mean by that is just like facing our fears without doing compulsions.
You should probably, did we give an example of what's a good example of an exposure?
Yeah. Is there a particular theme that you want me to go into, or should I just pick one?
I think most people know about contamination, and that might be an easy one to.
Okay. Sure. So we'll stick with the old school theme. This one doesn't come up quite as much anymore, but we still see it.
Yeah.
Where people are terrified that they're going to be contaminated with HIV, with the virus, right?
Okay.
So they'll avoid doorknobs, they'll wash their hands excessively, and they'll use napkins. They'll do all sorts of compulsions to prevent the fear.
Right.
So just one example potentially of an exposure exercise would be touching a doorknob on purpose, taking their hand, contaminating their face, contaminating their body, because that way we can't get rid of it, right? Once it's on us, and sitting and hanging out with it, right? And it's probably going to create immense discomfort and anxiety for a while until it stops. And hopefully people at that point are going to have the tools and the skills to be able to tolerate that level of discomfort and distress. And there's lots of different types of therapy we borrow from to help people step back and like ride the wave of their anxiety. But if they're able to hang out without washing, they'll feel better at some point. And then we do it again and they'll get freaked out, but a little bit less so. And they'll do it to the point where they could touch a doorknob, they could touch their face, their body. They barely feel anything at all.
So for people that have fear of germs, you give them germs, basically.
Yeah, and we don't give them like actual germs.
Of course,
we never but we give them uncertainty that they could be touching germs, right? Because OCD, it's all about uncertainty and it's all about the what ifs. So essentially, we're teaching people that just because they feel uncertain, that doesn't mean that there's anything dangerous. That doesn't mean they're in harm's way, even though it certainly feels like it does. But we're teaching that part of their brain that it's okay to feel that way without going away or acting on it. And eventually it'll go away on its own. And then they start associating those fear thoughts with safety, and they feel safer eventually.
Yeah, one of the things I was actually thinking about when I was learning about OCD and treating it, I always thought about, okay, this person has a fear of germs, right? If we start exposing them to the germs, or even just imagining having germs and they actually get sick the next week, like, what am I going to do then?
Yeah. It happens sometimes,
The timing is just off, right?
Yeah, you have like magical thinking OCD where people are afraid that if they do something like step on a crack or have a negative thought, something bad will happen to a family member, right? And like you may do an exposure with somebody where you purposely have them have a negative.
I want to move the mic.
Sure.
Yeah.
You might do an exposure where you purposely have somebody have a negative thought, and the next week their uncle dies, right? It happens.
What do you do in those situations?
Yeah, well, let's try to kill 2 more uncles.
Wow. Okay.
Right? And the reason for that again is because things happen in life. We all take risks every day, and OCD does not like that. It does not want it. And we really want to teach our brain that just because we have a thought, no bearing on reality whatsoever, despite what your OCD wants you to think. So we keep at it. And if people go through 3 or 4 uncles, okay, sure, fine.
Okay. Yeah, seriously. You have to do that.
You have to do it, or else you're not going to get better. And for people that have debilitating OCD, it takes everything. Right. So we got to really be aggressive against this stuff. Yeah.
Yeah. I think a regular CBT therapist or even a psychodynamic therapist, I don't know if they would have the level of comfort to say, okay, your uncle just died. We need to keep going. Yeah. I don't know. Because again, your training is very specialized for this, and your mind is geared towards making sure that you do not allow this to actually take hold of someone despite what's going on externally.
Yeah. Absolutely. That's exactly right. And people with OCD, like part of the disorder is treating their thoughts too seriously, right? Like their intrusive thought pops up and their flight or fight system goes haywire and they become terrified of the thoughts that pop up in their mind, which of course leads to more thoughts popping up. And we really want to teach people differently. We want to help people let go of any control they have over their thoughts and getting back to living their lives.
Okay.
Yeah, I can't tell you how many times I've had a client wish death, stroke, cancer upon myself as part of the exposure exercises.
Really? Wow.
I'm still here. Not to give people reassurance, but
well, you are here. Yeah. All right. Well, that just shows how much confidence you have, and they don't have the ability to hurt you because, I mean,
thoughts are thoughts, right? Regardless of the content of what our thoughts say. It's neurochemicals and electricity going on in our brain based off of experiences in the past. And if we were able to teach our brain to see that, it can free up so much life.
Yeah, that's a lot of buy-in from you, though, because if you actually thought that they had that power to kill you, I mean, you'd be dead many, many times.
I'd probably died many of deaths. Yeah, exactly.
All right, so we know what OCD is. We know the type of treatment.
Yeah.
It goes for OCD. How long can someone expect, on average? Because I know it's different for everybody, but on average, how long does treatment usually last?
So typically, especially if people are going through a more structured protocol, we say like 12 to 25 sessions. Okay. But as you said, it could definitely vary, and especially if there's other issues people are dealing with. We see a lot of trauma, kind of comorbid anxiety issues, and that could absolutely prolong the treatment. But 12 to 25, I'd say, is a safe average. And some people get better a lot faster too. Right. Once they kind of get OCD, how it works, and we start practicing exposures together, they're sort of off to the races. And kind of, like I said, it can't help but melt away if we drop the fight, if we drop the resistance and face the scary stuff.
Okay. And how long, say someone reaches remission, how long after reaching remission do some people might have a relapse? How long can they expect for that to last?
Yeah. Honestly, it really depends. There's some research. Research can only go so far in terms of following up, but like 8-10 years with treatment gains being maintained. It's one of those things, like, it's really about once you get the principles of ERP, and I like to encourage my clients, it's not even about doing one exposure or one skill. It's about living a lifestyle, right? It's like changing our whole relationship with intrusive thoughts and the nature of fear. And if people get that, they sort of get better and they stay better. And of course, when hard things happen, OC is more likely to come back. But once they've gone through exposure and response prevention, usually 1 or 2 sessions can help them get right back on track.
Get their booster.
Yeah. Get their booster. Yeah, that's right.
All right. So when, because I'm a psychiatrist, keep saying that. I think that's the 3rd time I've said that. Damn it. When do you call in a psychiatrist? What are the, where's the line at where, okay, ERP is enough for this? When do you call in for assistance for medications? Yeah.
So a lot of it, I leave it up to my clients, just their comfort level. Okay. And that's a conversation we have from the get-go. Some people want to start medications immediately. Then I'll call in the psychiatry. Yeah. Some people want to try the behavior route first. But always acknowledging that psychiatry is an option down the road if we need to. There's a few instances where I'll be a lot more directive. It's like, yeah, we need to get psychiatry on board. So for example, that would be if somebody's OCD is so severe that it's impacting their ability to come to therapy sessions, or if it's so severe that we can't start exposure work because anything is too triggering, definitely need psychiatric help. Or if their symptoms are causing really severe mood shift, if they're becoming suicidal, if it's interfering their ability to really perform in important parts of their life, right? Like if it's a kid or teen, if their grades are falling or they can't be social, if it's an adult and they're really having trouble at work, I feel like we don't want to wait for therapy. We want to get psychiatry as soon as possible to help create some stability while we go into treatment. Okay. So I'll be more directive in those cases to getting a psychiatrist on board.
But outside of that, it's usually, is the patient comfortable with?
Yeah, it's totally like their preference. Yeah.
Okay. All right. Well, I don't think I have any other questions. I mean, the question for you now is, with you being a specialist and having your own practice, give the people your information. Let them know how to find you if they're interested in speaking with someone that has OCD expertise.
Awesome. So my practice is Beachfront Anxiety Specialists, and our website is www.beachfrontanxiety.com. And my email, my phone number is on the website. People can feel free to reach out to me. Our office is in Redondo Beach, but myself and my clinicians are seeing people virtually or in person as well. So there are different options. And then, like I said, too, the IOCDF, the International OCD Foundation, has some great OCD resources if people are interested in finding other providers or just kind of like learning more about OCD and how it works. It's an awesome organization.
Okay, awesome. So they can go to that website and it'll be just like a listing of people.
Exactly. I believe it's iocdf.org, or you can just type in International OCD Foundation, Google, and it'll take you right there.
Okay. Okay. Well, awesome. Anything else? Any other thoughts on your mind?
I think we covered it. I really appreciate these are some awesome, insightful questions, and I love talking about OCD. So thank you so much for having me on today.
Absolutely. I remember your face kind of lights up when you talk about OCD.
Yeah.
It's on camera, actually. So
cool. Beautiful. So yeah, it'll light up for everybody to see. But it's I know OCD. It's causes so much pain, and like we talked about it, there's so much stigma behind it and misconceptualizations of it, but it's so treatable. And in my practice, yeah, people get better. And it's nothing magic that we do. It's just having good OCD informed therapy. It's nothing better than it.
Yeah, I will say out of all of the conditions, OCD is one of those conditions that I would say really responds to psychological behavioral management, more so than a lot of the other DSM conditions.
There's something neurological about how the brain works and how fear's conditioned, how compulsions essentially feed into the intrusive thought cycles, that once we provide education and help people respond differently, there's like some sort of rewiring that happens and people get better.
Yeah, it's amazing. Also, that's why I asked you about remission and everything too. 8 to 10 years, huh?
Yeah.
Wow.
Yeah, depending on the studies.
Of course, yeah.
But yeah, people once they get it and they get the principles, they could just, they sort of like live their life, and it's pretty powerful stuff.
Okay. Well, that's amazing. Thank you so much for coming in. We're all finished.
Thank you so much.
Yeah, you did a great job.